Welcome to The Explainer. Today we're going to break down a really common childhood viral infection you'll definitely see in your career, Herpangina. It's one of those classic presentations, and once you know the signs, you'll be able to spot it a mile away.
So let's start with a situation you can probably picture pretty clearly. It's late summer, a 7-year-old kid is in your chair, and they just feel miserable. They've got a fever, a super sore throat, and it hurts to swallow. Right away, your brain should be firing off a list of possibilities, right? Well, we're about to zero in on one of the most important ones.
And boom, right there near the top of your list should be Herpangina. Now the name might sound a little intimidating, but the definition is actually crystal clear. It's a viral infection, and the absolute key thing to look for is this vesicular rash, little blisters on the mucous membranes at the very back of the mouth. And trust me, that location is everything.
Okay, so here's our game plan for this explainer. We're going to start with the virus itself, the culprit. Then we'll get into how it spreads, what it actually looks like in a patient, and take a peek at the microscopic clues. Then comes the really important part, the differential diagnosis. And we'll finish up with how you manage the patient.
All right, first things first. Let's meet the little troublemaker behind this whole thing. Knowing exactly what we're up against is step one to really understanding the disease.
So Herpangina is caused by a bug from the picornavirus family. And a fun fact, pico just means small, so it's literally a small RNA virus. More specifically, it belongs to a group of enteroviruses called Coxsackieviruses. You'll see a bunch of different types causing it, but the usual suspects are types A1 through 6, A8, A10, and A22. And just to keep things interesting, sometimes a type B virus can even crash the party.
Okay, so we know what it is, but how does this tiny virus manage to make a kid feel so crummy? Well, the way it gets around is super straightforward, and it really explains why we see these outbreaks in certain places.
You know, the way this gets around is not complicated at all. The virus spreads through direct contact with saliva, we're talking coughs, sneezes, kids sharing toys, or through the fecal-oral route. And that second one is a huge reason why this spreads like wildfire in daycares and preschools where hygiene habits are, well, still a work in progress. Once it's transmitted, it gets to work and starts up an acute infection.
Now for the part that really matters when that patient is sitting right in front of you, the signs and symptoms. What are you actually going to see? What's the kid going to complain about? The clinical features of Herpangina are pretty unique.
So after the virus gets in, there's a short incubation period, and then bam, it kicks off with these general, kind of flu-like symptoms. The child will just feel blah, that's the malaise. They'll probably have a fever, but the two big ones, the complaints that will likely bring them to you, are dysphagia, which is just a fancy way of saying it hurts to swallow, and a really, really sore throat. And who gets this? Well, it's pretty much a classic childhood illness. I mean, sure, adults can get it, but you're almost always going to see this in kids between the ages of 3 and 10. You know, that's prime time for daycare, kindergarten, elementary school, where viruses like this just love to make the rounds.
Okay, so the fever and feeling crummy, that could be anything, right? But what you see inside the mouth, that's the dead giveaway. The absolute hallmark of Herpangina is what we call a vesicular enanthem. That sounds complicated, but it just means a rash of little blisters, or vesicles, on the inside mucous membranes. They don't stick around for long, though. They pop pretty fast and turn into these little painful ulcers.
Okay, everybody, listen up. If you take away only one thing from this whole explainer, let it be this. Location. 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 So many other viral things can happen in the mouth, but Herpangina loves to hang out in the back of the oral cavity. Just knowing this one fact will help you slash your list of possibilities in half. It is so, so important. So where exactly are we looking? This is your treasure map. You're going to find these ulcers almost exclusively on the soft palate, those little arches in the back called the fascial pillars, and on the tonsils themselves.
On top of those specific little ulcers, when you look in there, the whole area is just going to look angry and red. That's what we call a diffuse erythematous pharyngitis. And yeah, that's a huge reason why it hurts so much for them to swallow. The whole throat is inflamed.
The calendar can also be your friend here. Herpangina isn't something you see much in the winter. It's really a summer or early fall kind of thing. The little sores themselves only last about 4 to 6 days, and the whole illness is usually over and done with in under a week. It's self-limiting.
Okay, let's put on our lab coats for a second. Now, are you ever going to biopsy one of these? Almost certainly not. The diagnosis is purely clinical. But for our own academic understanding, knowing what's happening on a cellular level is super interesting and helps complete the picture.
So if we did put it under a microscope, what would we see?
Well, you'd see the virus just wrecking the epithelial cells. They become necrotic, which is what creates that ulcer. And underneath that mess, the tissue is all inflamed. The blood vessels are swollen, and you've got this classic calling card of a viral infection. A bunch of lymphocytes hanging out around those vessels. It's a textbook viral response.
And this is where the rubber meets the road. This is where you earn your stripes as a diagnostician, telling Herpangina apart from all the other things that can cause mouth sores in a kid. This is a crucial clinical skill. Okay, let's run through the lookalikes. First, hand, foot, and mouth disease. It's caused by a cousin virus, but the name tells you everything. Herpangina does not have a skin rash. HFM does. Simple. Next, primary herpetic gingivostomatitis. This one can have ulcers anywhere, but the key is in the name again, gingivostomatitis. You'll see this angry, inflamed gingiva. The gums will look like they're on fire. You don't get that with Herpangina. And finally, strep throat. Sure, you get a sore pharynx, but you do not get those little blisters or vesicles first. See? When you know what to look for, it's just a process of elimination.
So, you've nailed the diagnosis. Now what do you do? The great news here is that the management plan is actually really straightforward, and it's all about supportive care.
I love this quote from the textbook because it really says it all. The virus just runs its course and then it's gone. Your biggest job, honestly, is to be the voice of calm for the parents and make the child as comfortable as possible while their own body does the work.
So here's your playbook. Number 1, reassure the parents. Tell them, hey, this is super common, it's viral, and it's gonna go away on its own. Number 2, focus on comfort. Maybe some analgesics for the pain and fever. And number 3, and this is a big one, push fluids. It hurts to swallow, so kids might not want to drink. Dehydration is a real risk, so you have to stay on top of that. And finally, remember, no special antiviral meds are needed for this.
All right, let's wrap this all up with your diagnostic cheat sheet. If you want to spot Herpangina like a pro, just run through these 4 points in your head. The patient's age, probably 3 to 10. The lesion location, way in the back. The timing, summer or early fall. And the key things that aren't there, no skin rash and no major gingivitis. If you've got those 4, you can be pretty darn confident in your diagnosis.
And that's Herpangina in a nutshell. We've gone from the virus all the way to the treatment plan. But I'll leave you with this final thought to chew on. We've talked about the textbook case, right? The perfect example. But what do you do when a patient walks in and they don't quite fit the mold? That's where the real art of being a clinician comes in.